So I'm happy to be here today and thank the organizers. I'm going to talk a little bit about some findings that we've had that really can sort of classify T-cell products that correlate with clinical efficacy in B-ALL, specifically talking about CAR T-cells. And I think before you can really talk about what are successes, it's important to review the causes of failure. So there's been a lot of excitement about CAR T-cells in the field of B-ALL, but it doesn't work for all people, and there's sort of three primary reasons why it doesn't work. The first is that not everybody has a CAR product for infusion. So the inability to manufacture a therapeutic product, depending on the CAR type, has failure rates of up to 25%. Second, for those that do receive a CAR product, not everybody gets into remission. So about 10 to 20% of patients will not obtain remission after infusion. And then lastly, those that do get into remission don't have sustained remission. So about a year after infusion, about 40 to 50% of those that have responded have recurred. And there's two mechanisms of recurrence. The first is that there's premature loss of the CAR T cells. So all the leukemia cells were not eradicated, and the leukemia quickly recurs. And then the second is antigen loss, which is a little bit of a different mechanism. Regardless of whether or not those CAR T cells have persisted, patients' leukemia can evolve and lose the target antigen, and in more rare cases can actually undergo a lineage switch where their ALL becomes an AML in order to escape the targeting of the CAR. So what I'd like to do now is review some of our data that we've obtained from our Plateau-2 study. So this is a phase 1/2 trial using SCRI CAR19, which is a CD19 specific CAR T cell, in relapse refractory B-ALL patients. For the phase 1 portion of the study objectives were really to determine the feasibility of manufacturing a product, identifying the safety of the product, and really describing the full toxicity profile. And in the phase 2, we're further evaluating it for efficacy. And then the eligibility criteria is age between 1 and 27, and patients had to be at least 10 kilos in size, and that was due to manufacturing feasibility reasons and apheresis. Patients, of course, had to have a diagnosis of relapse refractory CD19 positive ALL. And those that had undergone a transplant were not able to enroll if they had any active GVHD. And lastly, they had to have an absolute lymphocyte count of at least 100 cells per microliter. In the phase 1 portion of the study, we treated 43 patients at varying dose levels. We initiated at dose level 1, which was 500,000 CAR T cells per kilo, and escalated up to a total of 10 million CAR T cells per kilo, and ended up moving forward with a recommended phase 2 dose of 1 million CAR T cells per kilo. And then we moved into phase 2, and you'll notice a slight change in the name. So in phase 1, we refer to this as version 1 of the CAR product. And in phase 2, we refer to it as version 2, and I'll talk about the nuanced differences between those two products as we move through the talk. And of course, all the patients at phase 2 were treated at 1 million CAR T cells per kilo. So the first issue I want to tackle is product manufacturing. Here's this design schema for how we manufacture SCRI CAR19 V1. We have patients undergo apheresis. The apheresis product undergoes sequential selection for CD8 and CD4 enriched T cells. Those cells are then grown in separate cultures. The CD8s are stimulated on anti-CD3, CD28 beads in the presence of IL-2 and IL-15, and then the CD4s are stimulated on beads in the presence of IL-7 and IL-15. Those activated cells then undergo transduction with a lentiviral construct encoding for our CAR, which is shown, see if I can get this pointer to work. This is very cool if I can get it to work. Here, spotlight. The SCFV portion of this CAR is FMC63, which is a murine-based SCFV. We have a short spacer, and then we have 41BB as our co-stimulation. And then in addition to encoding for the CAR, we have an EGFR tag that follows the T2A. And here, this is shown in this cartoon. This truncated version of EGFR maintains the extracellular domain, but no intracellular domain, so there's no signaling capacity. But it does retain the binding domain to cetuximab. And in culture, we make use of this by doing an EGFRT enrichment on a Clinimax midway through culture to purify for the CAR-positive cells. They're then expanded several more days in culture, cryopreserved, and then the idea is that they're infused in the patient at a 1-to-1 ratio of CD4s to CD8s. The pillars of our manufacturing, how did we come up with this? We really had several reasons for doing the upfront CD4 and CD8 selection. The first being that it allows for monocyte depletion. As shown in the graphs here by a paper by Slaney et al., that shows the inhibitory function that monocytes can have when in culture with T cells. And in both of these graphs, they either isolated splenocytes or lymphocytes and expanded them as isolated cells, and they had really great expansion. However, when they seeded them with decreasing ratios of monocytes, so when it was 1-to-1 of T cells to monocytes, you see a very inhibited expansion. So we felt like it was important for us to be able to do this selection to get rid of the monocytes. And then secondly, doing this selected product allows us to really define what that ratio of CD4 to CD8 cells is for the patient. And this was preclinical work done in Stan Riddell's lab, showing that when you had a defined ratio, you could increase the potency. And in this experiment, they had mice that were given a leukemia. Those mice who were treated with control obviously died very quickly. Those who were treated with PBMCs transduced to express the CAR had a little bit of delay in their tumor progression, but ultimately succumbed to the tumor. If you had CD8 cells selected for central memory and infused those, they performed similar to the PBMCs. And then if you had CD4 cells that were naive and then transduced, they did a little bit better than controls, but not much. However, if you use the same total dose of CAR T cells, but split it equally between 8 central memory and 4 naive, you saw that the mice could be cured. And similarly, if you selected on central memory and 4s unselected, you had some mice that were cured and a very delayed tumor progression. In the field of pediatrics, we opted to move forward without a central memory selection due to the fact that we were not going to have large apheresis products from these pediatric patients and had concerns that we would not be able to effectively obtain enough central memory cells from these patients. And then sort of the third pillar of our manufacturing platform is the homeostatic cytokines that we add. So we know that homeostatic cytokines can allow for the rescue of poor starting product. IL-7 supporting progenitor T cells, IL-15 supporting memory T cells. Shown in this graph was a paper from Dave Barrett's lab at CHOP, where he had patient samples from lymphoma and leukemia patients who underwent expansion but had poor expansion, and oftentimes these patients would not qualify to have a CAR T cell product. However, when he added IL-7 and IL-15, he was able to rescue these cells and have culture expansion. So with this manufacturing strategy, we were 100% successful in manufacturing products from all 45 patients that enrolled on the phase 1 portion of the study. The average ALC at the time of apheresis was 1228. The days in culture, CD8s were in culture for a median of 15 days with a range of 11 to 22, and CD4s were in culture for 14 days with a range of 10 to 20. One thing that we noted was that mid-culture EGFR-T enrichment really was hard on the cells, and following that, it took several days for the cells to recover and prolonged the culture time, and we'll talk more about that later. And then 93% of patients had this 1-to-1 prescribed ratio of CD4s to CD8s. There were 2 patients who were unable to have a CD4 product manufactured, and 1 patient who had a skewed ratio of 70 to 30 in favor of CD8s. And then in the graphs, what you can see is starting product, so the cells obtained at the time of apheresis are noted in red, are very widespread in terms of expression of CD127, CCR7, CD27, and CD45RA. However, at the end of culture, you can see that the variability is much tighter, so final product is noted in blue, and they look much more similar than they did when they started. The next graph in the middle shows the EGFR purity, so how much CAR T cells do we have in our product, and because of that mid-culture selection, we have very pure products, sometimes with near 100% CAR expressing T cells. And then in the far right, left, I get confused. We'll try the magic pointer again. Here we go. The MFI is more tightly controlled than it would be in an unselected product, and what we find is that the selection actually expresses for the high expressing CAR populations. So we've sort of talked about manufacturing success, how we can improve the manufacturing success. Now we're going to move to talk about induction of remission. So this product performs very well. In the 43 patients who were infused, 40 of them got into an MRD negative CR, which for ALL is the best response you can have. But we were not able to identify any clinical factors to identify the non-responders. So you can see here in this graph with force plot that whether it was disease burden, dose, lymphodepletion, transplant status, or relapse status, all of those patients were equally likely to respond. So we wanted to ask the question, could starting product, which is again the apheresis product, or final product, which is the cryopreserved CAR T-cell product, could any factors of those be identified to predict the non-responders? So when we move forward with this work, we actually identified a group of 5 patients that we termed the dysfunctional responders. The first 3 were the 3 that did not obtain a CR, and of those 3 patients, 2 of them engrafted and actually expanded their CAR T cells, had evidence of CRS and some anti-CD19 activity. One patient was able to resolve their peripheral blasts, which were 100,000, and then one subject had a partial response going down to 20% disease in their marrow, and then one subject had no evidence of engraftment or expansion and no CRS. There were 2 additional patients we decided to group with these 3 non-responders, and they were 2 patients who did obtain a CR 3 weeks after infusion, but that CR was short-lived, and within a week or 2, they had CD19 disease progression. And those patients, despite having engraftment and ongoing persistence of their CAR T cells, had their disease progression, suggesting that their T cells were non-functional. And when we looked at this group, again, no clinical factors were able to identify or isolate this group. So we initially looked at the final products, and as I showed before, they're very homogeneous, and we weren't able to identify any differences of the final product. So we moved to look at the starting material, the starting product, and interestingly, what we found was those that were in the dysfunctional responder group had increased expression of PD-1 and LAG-3 in the CD8 cells and increased expression of PD-1 in the CD4 cells. So you can see the top row is our gating strategy, and then the middle row is of the CD8 cells. And what you can note is that the expression of PD-1 in the dysfunctional responders noted in orange, and LAG-3 was statistically significant. Not much difference in TIM-3. And then similarly on the CD4s, you can see increased expression of PD-1 in those dysfunctional responders. LAG-3 is increased, but not significantly, and then TIM-3 maybe a little bit up, but obviously not significant. And this is all with the caveat, these are small numbers. So with that information, we also decided to look at the functional response of those starting products. So what was their ability to secrete cytokines? And through a regression tree analysis, we identified that the dysfunctional responders congregated together with 2 factors. One, they had higher expression of LAG-3, and they had low expression of TNF-alpha. And so all 5 of these dysfunctional responders grouped together. And I'll note that the 3 green dots, the 3 functional responders that kind of cluster with them, had recurrence with CD19 positive disease within several months of their initial remission. So the next steps for us with this finding is really to validate this in a larger number of subjects. And if validated, it has the ability for us to identify subjects up front who would be at risk of having a dysfunctional response based on their starting product phenotypes, allowing 2 potential options. One, is there a way we could modify the culture conditions for those with poor starting product? Or alternatively, could we delay collection until an appropriate time? So with that, I'll now switch to this issue of durable remission. We know that patients who respond will have a high risk of recurrence. So the leukemia-free survival at 1 year following SARI CAR19V1 is about 60%. So 40% of those responders have lost their remission by a year. And we also identified that ongoing functional persistence of the CAR T cells, which we measure with B-cell aplasia, is protective against recurrence of CD19 positive disease. One of those most important factors that protects you is ongoing functional persistence, and that can be influenced by the amount of CD19 positive cells you have in your bone marrow prior to lymphodepletion. So we call this your CD19 antigen burden. And this includes not only your malignant CD19 population, but also your benign normal B-cell population. And what you can see on the Kaplan-Meier curve is the survival, or what's the chance that you'll have ongoing B-cell aplasia over time. And those that have high antigen burden, greater than 15% in the marrow, had a persistence of 6.4 months versus those that had low antigen burden, which was defined as 1.7 months. And we also noted that loss of B-cell aplasia, so loss of functional persistence, is associated with a hazard ratio of 34 in terms of your risk of recurrence. One of the initial questions was, if persistence is good and you lose persistence, why can't you just reinfuse the CAR T cells? And what we have found is that reinfusion of CAR T cells is mostly unsuccessful, and that's due to the development of a T-cell mediated rejection response in the majority of patients who lose persistence. And that rejection response is directed against the murine-derived SCFV binder. So how long is persistence required to maintain remission? We don't have a definitive answer to that, but longer does seem better. So what you can see here is we've divided the patients that were the functional responders into 3 groups. Those that had long persistence, greater than or equal to 6 months, shown in green. Those with medium duration of persistence between 2 and 6 months, shown in purple. And then short duration of persistence, which is shown in blue, and that's less than 2 months. And so leukemia-free survival, when looking just at the risk of CD19 positive relapse, is really influenced by this, with those who have the longest persistence having the best chance of staying in remission. So what factors could identify the products that have this ideal attribute of long B-cell aplasia or long persistence? So we did several experiments, and a few of those are shown here. The top row of graphs is showing cytokine production. So cryopreserved CAR T-cell products, both the CD4s and CD8s, were thawed, and then they were stimulated at a 1-to-1 ratio, just like we do in the patients, on CD19 positive K562 cells for an hour. We then added Refeldin and cultured for another 17 hours and looked at the cytokine production. And what we found was that interferon gamma was the highest in the long BCA, so the green group, and then successively declined between the medium and the short. Similar trends were seen with TNF-alpha, and this met statistical significance. And with IL-2, there wasn't much IL-2 production across all of them, but it is notable that the blue, the short BCA, had very little IL-2 production. And then when we looked at measures of activation or exhaustion, we thawed the cells and stained them. We did not do any additional stimulation. And what we found is that although markers of PD-1 and LAG-3 appeared similar, those that had long persistence had less TIM-3 expression. So this final product with high TNF-alpha and low TIM-3 was identifying the group that had the longest persistence and as an ideal product. So as we were gathering this information, we were also making some manufacturing changes as we moved into the phase 2 of PLAT2, and I'm going to review that now. So here's the manufacturing schema for SCRI CAR19V2, and there were 2 main differences that we changed for. One was that we switched the manufacturer of the CD3, CD28 beads due to some IP issues, and then the second was that because the cells really seemed to beat up with that EGFRT enrichment, we decided we would drop that EGFRT enrichment. And as we started treating patients, we had treated 21 patients, and we noted the MRD rate was pretty similar to our phase 1, with 86% of the patients obtaining an MRD negative remission. But what was interesting to us is that we were noticing that these patients seemed to be doing better and that the durability of the remission seemed improved. So you can see the leukemia-free survival Kaplan-Meier curve, with the blue line being the initial phase 1 with the V1 product and the red line being the phase 2 with the V2 product. And although not significant, leukemia-free survival was improved. And so then it was next that we looked at, well, how are these CAR T cells doing? Are they having better persistence? And what we found was that the B-cell aplasia, or the marker of functional persistence, was actually greatly improved in a statistically significant way for the V2 product. So this led us to do some paired product comparisons of V1 versus V2. And what I'm showing here is that there were 6 patients who we manufactured both a V1 and a V2 product for. Most of these products were obtained from the same starting product. However, the 2 light orange lines had reapheresis to derive their V1 product shown in orange and red versus the V2 product shown in blue. And what we found is that favorable markers, so CCR7 positive cells, CD45RA positive, CCR7 positive, and CD127 positive, were significantly elevated in these V2 product. And then sort of going along with what we found in the favorable products in terms of long persistence, these V2 products had higher TNF-alpha secretion and then remarkably lower PD-1 expression. And when we looked at the CD4 cells, we found similar things with less significance. So the two significant findings that we saw were that the CD45RA negative, CCR7 negative population was lower in the V2 product, as was PD1. So what did we learn from this? We learned that small manufacturing changes can really create large differences in the clinical performance of products manufactured from the same starting material and the same CAR construct. And two possible causes of this could be, one, we changed the bead manufacturer, but two, dropping that EGFRT enrichment step. And the question that begs is, does the EGFRT enrichment select for a high expressing CAR T cell that might be more prone to exhaustion and hence have shorter persistence? But also, is the mid EGFRT selection just deleterious to the cells? I think this is sort of made us think about Michel Sadeline's paper from a few years ago, where they integrated the CAR construct into the TRAC locus, and they saw that these CAR T cells were more potent than those who underwent traditional retroviral integration. And so in a mouse experiment, in the blue line is the CAR T cells that were integrated specifically into the TRAC locus, and you can see that those mice did better. And when you looked at the MFI of the CAR T cells, the TRAC integrated CAR T cells are shown in blue, and the retroviral CAR T cells are shown in the red. You can see that the MFI is much lower. And what these, the phenotype of these cells is they are less activated and less exhausted. And so this could be a reason for why when we select for the high expressing CAR T cells, they don't perform as well in vivo. So to further address this question, we're now investigating product version 1.5. Where we have kept that manufacturing platform. We've gone back to the phase 1 beads, but we've continued with no mid-culture selection, and those results are pending, and we'll see how they compare to both the V1 and the V2 product. So just briefly now, we'll talk about some alternative products to enhance persistence and promote durable remissions. Plato-3 is our study really designed to overcome this clinical factor of low CD19 antigen burden, where patients are more likely to have short persistence of B-cell aplasia, therefore more likely to undergo recurrence. So for this study, what we've designed is a product that we call TAPCs, so T antigen presenting cells. We manufacture these cells using the same starting product that we use for their CAR T cells. We activate them on beads, transduce them with a lentiviral construct, shown in this cartoon that really, it just encodes for the CD19 extracellular domain, no intracellular domain, so it tags the T cells with the CD19, but it has no signaling capacity. These cells are expanded with IL-2 for 10 days and then cryopreserved. They are able to be identified by the co-expression of CD3 and CD19, and in vitro are able, the CAR T cells are able to target and kill these TAPCs. So our early clinical experience has been really very favorable. Patients are identified up front as being at risk of losing their CAR T cell graft. And so what you can see here is the blue line is engraftment of CAR T cells over time. The solid red triangles are the infusions of TAPCs, and the green line is the engraftment of the TAPCs. So what you can see is shortly after the CAR T cell infusion, there's a rapid contraction. TAPC infusions then start once every 4 weeks. And after the infusion, you can see a little blip of the TAPCs in the peripheral blood, and then the CAR T cells are able to eradicate them. And what you can see is not after all of the TAPC infusions, but some of them, this episodic re-expansion where you actually see the CAR T cells expanding, presumably in relation to the TAPC infusion. And we've seen improved persistence in these patients. And then lastly, we have a study, Plato-6, where we're using a fully human scFv-based CD19 CAR, and we have termed this SCRI HuCAR19V1. You'll see that the manufacturing platform is near identical to our Plato-2 study, with the hypothesis that the fully human scFv will provide a more durable engraftment, as it's less likely to invoke a rejection response, and that if loss is due to exhaustion, potentially we could be successful in repeat infusions, since most of the rejection responses are based against the murine scFv. Our early clinical experience so far has been really favorable. This is an example of a patient who had initially received tisagenlecleucel. They developed B-cell aplasia, but then lost their B-cell aplasia and lost their CAR T cells and went on to have a CD19 positive recurrence. They then enrolled on Plato-2 and got SCRI CAR19 and had a rejection response noted. So then they enrolled on Plato-6 and they got the human CAR, and they were able to get into remission. And you can see that on this graph here. The black line indicates the percent of leukemia in the bone marrow over time. The green is the lack of engraftment of the murine-based CAR-19. And then following infusion of the human CAR, there was a rapid expansion of those CAR T cells in the peripheral blood, combined with a marked decrease in remission of the leukemia. So conclusions. What are the T cell product attributes that are associated with efficacy? Defined composition products with homeostatic cytokines can enable very high manufacturing success. The dysfunctional responders, those that don't obtain remission or a very short remission, may be identified up front based on their initial starting product T cell phenotypes and functional attributes. And engineering durable engraftment of CAR T cells is really essential to maintaining remission, with a focus on culture methods that could enhance the ideal characteristics of final products. You could provide additional CD19 antigen for those with low antigen burden. Focusing on CAR constructs that won't develop a rejection response. And then lastly, we didn't have much time to touch on this today, but dual targeting products may overcome antigen escape. So with that, I would just like to acknowledge all of my collaborators at Seattle Children's, at CHLA and Children's Hospital of Oakland, and our funders, and would be happy to take questions.
Thank you very much for this beautiful presentation. This paper is open for questions. So I will start. Between your different manufacturing platforms, did you see differences in rate of CRS or neurotoxicity?
Yeah, it's an excellent question, and we did. So when we moved from the V1 to the V2 product, we noted that the onset of CRS was about a day to a day and a half earlier than with the V1 product, and similar neurotoxicity, the onset was about a day earlier with the V2 product, suggesting that these really are two very functionally different products in terms of their toxicity profiles.
And did you see different grades in terms of also neurotox and CRS?
Yeah, we saw the same overall grade of CRS and neurotox. With the V2 product, we had our first case of cerebral edema that was fatal, and that was one of the reasons why we switched to a 1.5 version. I think over time, I'm not sure that that was actually the cause of the cerebral edema, but I think it's important when people are interrogating new products that just because you're using the same CAR construct, you could have very different CAR products.
So I've noticed that in your optimized protocol in the construct, you do have kanamycin gene inside the construct. Is correct? And is this an issue?
It has not been an issue.
So in terms of the characterizations of the product or the cells that survived in the patient, expand, and the correlation to the length of the response, I know you showed the phenotype with STIM3 and LAG3 and PD-1. Did you see, in terms of CD4, CD8s or other subsets of T cells, indication of other characteristics of the cells that may be important?
Yeah, we have looked at that. For the vast majority of patients, whether they're dysfunctional responders or functional responders or have long BCA or short BCA, they all predominantly have a skewed CD8 ratio once the cells engraft. So they're infused at a 1-to-1 ratio. They quickly become 9-to-1, and sometimes we can only detect the CD8 cells, and periodically can detect the 4s with the contraction.
I'll ask one more question. In terms of the potential, the manufacturing process for a commercial product, what are your considerations for such a complex product?
Yeah, so we'll hear more about that later. We have moved forward with our newer studies, with the exception of Plat6. We kept on the old platform so we could compare it to Plat2, using a closed system with G-Rex, in which the cultures can be grown over 7 days with minimal manipulation in a closed system, so much less laborious. And we're currently interrogating the products that we've grown on the G-Rex versus those that are grown more traditionally to see if there may be some functional or phenotypic differences.
Okay, thank you very much.